legislature.
Thanks for watching TMA's Legislative News Hotline for Friday, May 22nd. I'm Brent Anir. Here in the final stretch of the legislative session, the biggest news this week is decisions on the budget. So we brought in the A-team for a budget analysis and an update on all the bill action. Here are TMA's Communications Vice President Steve Levine and Advocacy Vice President Darren Whitehurst.
Well, here we are according to my app with 11 days, 7 hours, and 50-some minutes left in this legislative session. Darren Whitehurst, what does your crystal ball show?
Well, Steve, I think that they are close to finishing up on the budget. They've got some tax discussions left. They basically are working this weekend. They've got deadlines. Tuesday's the last day that the House can report Senate bills on second reading. Wednesday's the last day that the Senate can report all bills in that chamber. So we are quickly coming to a close of the legislative session.
We're going to go through some of the key issues that TMA has been working on throughout this 140-day session. I'm going to start with the easy one and get tougher as we go along. So first of all, scope of practice. How many bad scope bills at this point are still in play?
Well, I can say confidently as of today, there are no scope bills that have passed the legislature that were not something that we agreed to, and really nothing big has passed this legislative session. And we're constantly monitoring, constantly watching until those final days that I mentioned earlier pass. We're going to keep our eye out to make sure that nothing bad passes.
So at least on the scope front, things are looking good.
Really good.
On the budget side, we've got some things that look good, some things that don't look quite as good.
Quite as good.
Let's start with the good news. Graduate medical education is something we've been pushing to expand for years, and it looks like we're really able to build on what we did last year.
Right. I think thanks to the leadership of Chairwoman Nelson, really took a prominent role in trying to get more graduate medical education in the state of Texas. We have been growing both our undergraduate and graduate slots, but we have slowly been losing ground on the number of graduate slots that we have. They put a lot of new money into new residency programs and trying to incentivize the right type of residency programs in the state of Texas, both on the primary care side and the specialty side.
By the right type, you mean those that meet the needs that the growing Texas population is certainly going to be needing over the course of the next decade or two.
That's exactly right.
And you said there is a good mix between programs that are dedicated for primary care and those that will go towards specialty care. Is that correct?
Well, and I think that Senator Nelson is committed, particularly to residencies that we have shortages in, trying to make sure that we have the doctors that we're for the 21st century that we need to take care of the population. And nowhere is that more pressing is on the primary care side, but we have a lot of specialties that we also have significant shortages in as well. And so, again, I think it's a good mix, a good legislative solution to a problem, and hopefully one that will take us into the next legislative session as we continue to build upon that success.
So the two-year budget looks good for GME, at least at this point, and there's also a talk of some sort of a long-term fund to help allow us to continue to grow that without having to go back to the legislature time after time asking them to appropriate additional funds.
That's right. That was included as part of Senate Bill 18, which was the enacting legislation for the money that was appropriated. And that does take some money out of the JUA, the liability writing coverage, coverage of last resort. They took some of the money out of that to set up this fund. There are also some other revenue sources that are funding that fund as well. So I think we'll have a good corpus to use in the future to make sure that these GME programs, because they're not a two-year program, it takes more than 2 years to train a doctor in their residency.
So that means to a certain degree, we won't be as subject to the vagaries of the other forces that come to play when the legislature makes some funding decisions.
That's right. Speaking
of forces that come to play, we tried awfully hard to bring back the Medicare parity payments for primary care services provided by most primary care Medicaid providers. It looked good. The $460 million was in the House version of the Senate. The final version of the budget that we're looking at now, unfortunately, has a big zero.
That doesn't include it, and I think that's one of the takeaways of the session we'll be most disappointed in. Is that I think it is a common sense approach to trying to make sure that there is access outside of the emergency room for people in the Medicaid population. As you know, it's getting increasingly difficult for doctors to see them in their office because the payment side for paying for a Medicaid person really doesn't cover the cost of providing the service to them. And so, really we're hoping the parity payment would get us back on track to where we need to be to make sure that doctors in the Medicaid system were getting an appropriate payment. At the end of the day, again, disappointed in what the legislature decided, because I think it's very, very short-sighted, and I think it's going to, increasingly burden our emergency rooms, and it's going to hurt practices in the places that we can at least afford to lose physician practices. The Valley, rural Texas, inner city, those are where it would have made a difference. And actually, the data that we had showed that when there was an uptick in payments as a part of the Affordable Care Act, is that physicians did participate in greater numbers, particularly on the primary care side.
So, is there any way we could have gotten our message across any stronger, do you think?
Well, again, at the end of the day, we are a grassroots organization, and we had several calls to action about hitting the conference committee members. I think that had it all set up well. I think that this legislature made getting it across the finish line very difficult. I'm committed and hopeful that we will go back to the next legislature and really profess about the importance of doing this, because we are quickly headed towards a crisis if we don't do anything. And
it might take a crisis to get the legislature to act, unfortunately.
Well, that's right. And the bottom line is that past legislatures have been equally as inactive in wanting to do anything proactive relating to Medicaid.
One good thing, or a couple good things we can say about the budget before we move on: mental health services, women's health services, public health services all got a good bump. And hopefully those weren't as expensive as some of these other items, but hopefully that'll make a big difference.
Hoping so, hoping it'll make a difference in physicians in their practices.
All right, let's, speaking of physicians and practices, let's talk about a couple health insurance and red tape sort of issues. One that has been moving along at a nice steady pace is the one that would move the the prescription drug monitoring program away from the Department of Public Safety to the Board of Pharmacy, hopefully make it more physician friendly, and it would also take away something that physicians haven't liked for a long time, isn't that right?
The Controlled Substances Registration process, and again, is that had numerous problems over the Department of Public Safety. They had problems developing an online system that would actually make a difference. So we've been working for the past several sessions to move that out of DPS and over to the Board of Pharmacy, and actually have been I think we are on the cusp of being successful. Is that the bill is on the House calendar. It is looking like everything is a go to make sure that happens. And again, at the end of the day, I think we'll help physicians by removing some of the bureaucracy in their practice and allow them to, hopefully better treat their patients.
And one less piece of paper they have to get every year.
Absolutely.
On the health insurance side, a couple issues that are creeping close. Not sure what our crystal ball is going to show us or what we're going to see in a week or so, but one relates to health insurance companies' use of virtual credit cards to pay doctors, which we call the pay to get paid program. And the other is some marks on some identification cards from the Affordable Care Act exchange plans, so doctors will know that they're dealing with someone who might be subject to the 90-day grace period. Want to give us some comments on either of those?
Well, they're sort of in both ends of the chamber. Is that the House Bill 1514 or Senate Bill 1514, House Bill 1514, the qualified health plan is over in the Senate. It is on the Senate intent calendar. Hopeful that we have the votes to bring it up. Basically, it will designate that on the card, in much the same way that a patient has any other card, but basically will designate them that they're receiving coverage through a qualified health plan. And so we'll hopefully remind the doctor's staff is that they need to talk with them about the importance of paying their premiums, because like you said, with a 90-day grace period, if they don't pay their premiums, for the first 30 days, the government will cover that cost. For the next 60 days, the plans are going to come back and recoup the payments from the doctors.
That means the doctor has to go after the patient for the payment, which is never a happy situation.
That's right. On the virtual credit card, basically increasingly what we're seeing is, as part of their contracts, is that the plans are including provisions allowing for payments under a virtual credit card. Unlike other payment types, the virtual credit card has a higher fee amount that's charged to the physician. And again, just don't think that it is right for the physicians to automatically be enrolled in those without their knowledge. That one is looking like it's on life support, is less likely at this point in time, have run into some roadblocks. But, you know, again, you never know until it's over. And so I'm hoping that we can maybe get at least one of those across the finish line, if not both.
And a couple other red tape reducers or things that we think will help doctors directly in the practice. First of all, we're taking a look at ways to enforce better networks in Medicaid HMOs. And secondly, some big changes at the Medicaid Office of Inspector General, which hopefully will take away one of the reasons why physicians are less likely to accept Medicaid patients. Finally, let's take a look at the public health front. We've really made some big progress. There's a couple good bills already on Governor Abbott's desk. One that would prohibit the sale of e-cigarettes or vapor products to minors. Another one that would help schools help students who have severe allergic reactions.
EpiPens.
EpiPens. So why did both of those go through so easy?
Well, you know, again,
or so quickly.
So quickly, you know, again, is that you're sometimes it's better to be lucky than good. And those bills, and actually more bills than I've ever seen in the early part of the legislative session in May. You know, the Senate bills and the House bill lined up perfectly, and so the Senate bill would come over, House bill would get on the calendar. They were able to substitute the Senate bill, which precluded you from having to go back to the other chamber. So they happened to be on that track, and that's what happened with the vapor products. That's what's happened with the EpiPen. You know, so just good fortune as much as anything, but got it across the finish line earlier than expected.
Well, good fortune is an important part of good public health.
That's right.
So we've got 11 plus days left, and then we start looking at the next election cycle.
Right.
It never stops here. What message do you have for Texas doctors as they look at the successes and failures here in the legislative process and start to think about the political process
well, you know,
coming up?
It's as go out and say is that, I mean, the state legislature and certainly Congress as well impact how you practice medicine in the state of Texas. And so those doctors that are sitting on the sideline not wanting to be involved because they don't like politics or whatever, they need to get over that and need to understand that the Texas legislature has an active role in relating to the practice of medicine through the regulation, through the medical board, through how they get paid with the Department of Insurance, through the Health and Human Services Commission and other areas. They determine how medicine is going to be practiced in the state of Texas. And so if you're not going to get involved, you're going to be a victim to what the legislature does to you. So I would encourage doctors to get involved, to get to know their legislators, to go to functions, to meet, to ask legislators to come out and see their practice. They should have nothing that they're ashamed of relating to their practice. They are there to take care of people. You know, heck, they got legislators that are their patients. Mm-hmm. And again, know that it's sometimes uncomfortable, but need to talk with them about the challenges that they face in their practice, because the legislature has a lot of sway over whether or not that becomes more difficult to do in the future or easier to do in the future.
All right, thanks. I think that wraps up the big issues. We've got a book this size full of things that the lobby team is tracking, but I think that's the most important things, again, with 11 plus days left in the legislative session. Hopefully all the good things will get across the finish line, and the not so good things will stay right where they are.
Yeah, I would like to mention one last thing is the texting while driving bill.
Texting while driving, that's a good thing that's not moving down the road.
That's right. We are, it is in the Senate right now. It is one vote short. We are targeting some of the members that are currently voting against, that are looking at voting against it, but really think that that's an important policy issue, certainly one that impacts patient care both now and the future, and so we'd like to try and make sure we get it across the finish line.
So we don't want people driving like this. We want people driving heads up.
That's right.
All right, our lobby team is driving heads up. The rest of your TMA team is driving heads up. We've got 11 days left to go.
Thanks, Steve.
Dan.
Thank you, gentlemen, and we will continue to update you on the progress of all of the unresolved bills. That's all for now. I'm Brent Annier with TMA. Please join us again next week for TMA's Legislative News Hotline.